We're going to shift our focus now to chronic adaptations that come along with long-term exercise training. So, when I say exercise training in this context, I mean how the body adapts over time. We could be talking about days, weeks, years, or even decades of training and how the body is going to adapt over time. So, some of the objectives here, I'm going to talk about the major principles of training. We'll talk about the physiological adaptations to aerobic exercise training, and then also chronic resistance training or weightlifting. So first of all, the principles of training. There's three major principles of training. The first is the principle of overload. And the principle of overload is relatively simple. It basically says for a tissue or system or even organ to improve its function, it must be subjected to a stimulus that it's not accustomed to. So in other words, if you want your body to improve its function, you have to stress it on some level. So in the simplest sense, this could be related to muscular strength. And we're probably all aware the best way to increase muscular strength is to lift some type of resistance that the muscle is not used to. So this could be going to the gym and lifting weights, or working around the house, or doing whatever where you're stressing the muscle by forcing it to overcome a resistance. So as an adaptation to that, the muscle is going to get stronger. And this also can apply to aerobic metabolism and aerobic training also. So by running, cycling on a regular basis, it basically is stressing the cardiovascular system, stressing some of the respiratory organs, and also stressing your aerobic metabolism, so your metabolic pathways that we talked about. So in response to that, those things are going to improve. Another principle that's important is specificity. So basically the principle of specificity says that the training effect is specific to the tissues or systems you train. So this could be as simple as the region of the body that's trained. If you train your upper body, you don't necessarily expect to see massive changes in the lower body. But it could be also related to systems of the body. So if you train aerobically and focus on aerobic type activity, you would not expect to see a lot of anaerobic improvements, and vice versa. If all you did was anaerobic activity, you would not expect to see massive changes in your aerobic metabolism or your cardiovascular system. And then lastly, reversibility basically stresses that these training adaptations that you can gain can be lost when you stop training. So this is sometimes called the principle of detraining, but detraining is just a term that means that you're doing the opposite of training. If you train for a while and then stop and your body kind of goes back to where it was before, that's the principle of reversibility. These adaptations can be reversed. So the way I have this presentation set up, we're going to focus on aerobic training adaptations first, and then I have it separated by system. So we're going to start with the cardiovascular system. So when we think about long-term aerobic training, this could be running on a regular basis, cycling, etc. Anything aerobic in nature. Over time, this is how the cardiovascular system will adapt. So the first thing I want to discuss is the heart. So the heart is going to adapt. This figure is showing cross-sectional data of different types of athletes. So you have untrained individuals, male and female, endurance runners, so here's aerobic athletes, cyclists, which are aerobic athletes, cross-country skiers, which are aerobic athletes. The wrestlers and shot putters would be considered more anaerobic athletes. So what we're looking at in this graph is left ventricular mass, or just overall mass of the left ventricle. So if we look at this, we see that, just to make this a little bit easier, males and females are shown on some of these, but not on all. So if we just focus on the males, so untrained, about 180 grams, any type of training, whether it's aerobic or anaerobic in nature, is going to increase left ventricular mass. And you see that going across here. That's one take-home message from this figure. The other take-home message would be the type of training is important. So Aerobic training definitely increases left ventricular mass, but more strength training, resistance training, which these athletes, the wrestlers and shot putters, would be involved in, that increases left ventricular mass even more. So even though the focus right now is to talk about aerobic training adaptations, it's convenient to throw this in there also to get an idea of how different types of training can affect the heart. So key point, aerobic training does increase left ventricular mass. Anaerobic training like strength training can increase left ventricular mass even more. And we're going to look at this even further in the next slide. So this is not as pretty, but it's the same idea. So we have a lot of variables related to the heart. We have runners, which are aerobic athletes, swimmers, which would be considered aerobic athletes, runners again, aerobic, wrestlers and shot putters again, which would be more strength, anaerobic, and then the normals, which would be the average person that's not training. So this is what we were talking about previously, left ventricular mass, and we see the same trend. So the normals have the lowest, the anaerobic athletes, the strength training athletes have the highest, and then the aerobic individuals are somewhere in the middle. Similarly, if we look at like the left ventricular wall thickness or the septum thickness, so that would be like the interventricular septum of the heart, we see a similar trend. So normals have the lowest, and then the highest would be the strength power athletes, and then the aerobic athletes would be a little bit more than the normal, but not as high as the strength training athletes. Then if we look up here, this is left ventricular internal diameter and left ventricular volume. So internal diameter is just measured in millimeters going across, like chamber size basically, and this is the volume of blood that the left ventricle can hold. So if we look at this, we see that normals are about 46, and then the aerobic athletes seem to have the highest. So on average, the aerobic athletes would have a greater chamber size of the left ventricle. As far as the strength training athletes, it looks like it might be a little bit higher. There's a big range here, so it makes it kind of confusing, but it's a little bit closer to the normals. For volume, similar concept, normals, and you have these high values for the aerobic athletes, and the anaerobic or strength athletes are going to be a little bit more than the normal, but not near as high as the aerobic athletes. Stroke volume, which would be determined in part by these variables up here, has the same trend. So even though there's nothing for the normal, you see that the stroke volumes of the aerobic athletes are much higher than those of the strength athletes. So key point, aerobic training leads to an increase in chamber size of the left ventricle. Resistance training may lead to a slight increase in chamber size, but the resistance training or strength training athletes seem to have more of an adaptation with the overall mass and thickness of the heart wall. So the term that we use to describe that increase in left ventricular chamber size is eccentric cardiac hypertrophy. So that means an increase in left ventricular chamber size. So in aerobic training, this happens. It's thought to be due to a chronic volume overload. What that means is every time you go out exercising, running, cycling, any type of aerobic exercise, as we saw previously, your stroke volume increases. So in response to that increase in stroke volume, if you're getting that every day or close to every day by aerobic training, the left ventricle has to adapt. So it adapts to this increased volume that's being put on it every day or every other day, however often you're exercising. So that will lead to an increase in left ventricular chamber size, which we call eccentric hypertrophy. There will be a slight increase in wall thickness with aerobic training, as we saw, but not near as much as you saw in the strength training athletes. This picture here shows long-term changes in one person, so this is a case study, but if you look as they went from 22 years old to 26 years old and trained for the Olympics, this is an aerobic athlete, their chamber size increased from 55 to 57, And then after they detrained, it says 6 years of detraining, even though it was a 10-year period, it reverts back to a lower level. So that eccentric hypertrophy is reversible upon detraining. You also see that they're getting a slight increase in left ventricular wall thickness, and that too reverts upon detraining. So other cardiovascular variables and how they adapt to training include blood. So the big change in blood that you get, or the big adaptation, is that blood volume increases. So there's a potential increase in hemoglobin, but by far the biggest thing about the blood that changes is that there's a massive increase in plasma volume. So this is due to the increase of plasma proteins in the blood, and that's going to stimulate the blood to retain more fluid. So plasma volume will go up anywhere from 12 to 20%. And this adaptation is important because it's one of the first adaptations that you're going to get. As soon as you start aerobic training, this can happen in as little as 5 to 7 days. More than likely it's going to be around 2 weeks, but the bottom line is that this is the first adaptation that your body is going to make. So your blood volume increases in an effort to try to increase cardiac output. And we'll talk about that shortly. So heart rate. So a lot of these variables we need to talk about how they change at rest and also during exercise. So at rest, heart rate's going to be lower after aerobic training. And this is due to a shift in your autonomic nervous system. Your resting heart rate is determined heavily by your parasympathetic nervous system. So with aerobic training, you get a shift to more parasympathetic outflow, and that's going to drive the resting heart rate down. So it's not uncommon to see aerobic athletes with resting heart rates in the 50s and even 40s. So submaximal exercise, what I mean in this regard is exercise at a submaximal level, but at the same absolute intensity. So the example I'm going to use is before training, if you measured your heart rate while you're running on a treadmill at a given speed, say 5 miles an hour, and then you trained for 3 months and came back and you ran on that same treadmill again at 5 miles an hour, how would your heart rate differ during that submaximal bout? Well, it would be lower in this case. So that 5 miles an hour is representing a less of an effort for the person after they've trained. So submaximal heart rate should be lower after training. Maximal exercise, maximal heart rate, believe it or not, no massive change. At least that's the conclusion that many have come to after looking at a lot of research on this topic. So the consensus is maximal heart rate does not significantly change with aerobic training. It may drift up, it may come down a little bit, but overall, when you look at many people, it pretty much stays relatively consistent. Remember, age is the number one variable that affects maximal heart rate. So if we look at this graph, and you'll see this a few times, we have endurance athletes in purple, and then yellow and turquoise represent sedentary people before they trained and then after training. So we see the endurance athletes have the lowest resting heart rate, and then the untrained individuals, after they trained, their resting heart rate came down. At a submaximal intensity, you can see also that the more training that was done, the lower the heart rate. And we can see, like, at a given intensity, looking along the x-axis, at a given intensity, you have a lower heart rate after training. And then maximal heart rate, you see some very small differences here, but for the most part, there's no drastic change. And that's what I was getting at. All right, stroke volume. Stroke volume is definitely going to go up after exercise training, after aerobic training, I should say. And so resting stroke volume will increase. There's a few mechanisms I want to bring up at the end. But at rest, at least, you could even say that if there's a slower resting heart rate, that allows more of the more time for the heart to fill up between beats. So even at rest, just that lower heart rate is going to allow stroke volume to increase. Submaximal exercise, it's going to be higher, and then maximal exercise is going to be higher after training. So the mechanisms include an increase in the preload, a reduction in afterload, and potentially an increase in contractility. So if you remember those terms from the cardiovascular discussion, preload definitely plays the biggest role, and two things we've already talked about lead to an increase in stroke volume during exercise and at rest. We had that increase in blood volume. So if there's more blood, that allows more filling of the ventricle, and thus more preload, which can lead to a greater stroke volume. And then the other variable that's important is the chamber size. So if there's an increase in chamber size of the left ventricle, that eccentric cardiac hypertrophy, that is going to allow the ventricle to fill up more and thus increasing the stroke volume. So another factor to consider, and if you look at this graph, you can see this, the untrained person, as they increase in intensity, their stroke volume tends to plateau a little bit, whereas the trained, their stroke volume continues to go up, and we had that discussion also when we were talking about the cardiovascular system. And this again is driven by that filling rate. After training, your heart has a greater ability to fill up at a quicker rate. So even though at high heart rates, there's very little diastolic time for the heart to fill up. In a well-trained person, their filling rate is so great, it doesn't really affect it that much. They can fill up the heart completely in a very, very short period of time. So now that we had the discussion of cardiac output and heart rate, now that we've discussed stroke volume and heart rate, we can determine what happens to cardiac output. So really, cardiac output is determined by the heart rate and stroke volume. So stroke volume went up, resting heart rate went down, so you would not expect to see a major change in cardiac output at rest. And that's what you're seeing here. Regardless of training, endurance athletes, sedentary or after training, they're all similar cardiac outputs at rest. However, maximal exercise, the well-trained individuals are going to have the highest cardiac output, and then the sedentary are going to have the lowest, and those sedentary people, after they trained, it's going to be higher. So maximal cardiac output increases after aerobic training, and it's even more pronounced in people that have been training for years and are well-trained athletes. And again, that maximal cardiac output is primarily a result of that increased maximal stroke volume, because maximal heart rate did not change that much. AVO2 difference. So this is our measure of oxygen extraction. So resting AVO2 difference doesn't really change with training, and the simple answer is it doesn't really need to. So at rest, you don't need to extract that much oxygen from the blood, so you wouldn't expect it to change. Where we want to focus on is maximal AVO2 difference. And if you look at this, you see that the sedentary, and then after those sedentary people trained, their maximal AVO2 difference went up pretty significantly. And that just signifies a better ability to extract oxygen from the blood. Then if we compare we'll say moderately trained people to the well-trained athletes, you don't see that big of a difference. Even though their fitness level is much greater, you don't see that much of a difference. So that tells us that one of the biggest differences between a well-trained athlete and just an average fit person, or let's say even a well-fit person who's not an elite athlete, goes back to the maximal stroke volume, because it doesn't look like, from this graph anyway, that it's that hard to increase your maximal AVO2 difference to a point that's comparable with an elite athlete. So that big stroke, the big variable that makes the elite athletes better in regards to fitness than, let's say, a moderately trained person is that maximal stroke volume. Other variables, total peripheral resistance. So remember, this is the resistance to blood flow in the vasculature. Resting, it's going to go down, and so there's less resistance at rest following exercise training. And this is one of the key mechanisms for reduction in blood pressure, resting blood pressure with aerobic training, and why exercise training is so good to lower resting blood pressure. Maximal exercise, it still should be a little bit lower. So if you compared maximal total peripheral resistance before and after training, you would expect TPR to go down after training at max. And that's just due, again, to more vasodilation, a better ability to vasodilate during exercise. As far as blood pressure goes, resting blood pressure will go down, and the primary reason is that drop in total peripheral resistance. Submaximal exercise, same thing. At a given absolute workload before and after training, blood pressure should be lower after training. And then maximal exercise, it really should be lower, but this one you have to take on a case-by-case basis. So in most cases, maximal blood pressure will be lower after exercise training. However, if the subject increased their cardiac output so much that it kind of overrides that drop in TPR, then it's possible to actually have a higher blood pressure at maximal exercise after training. And that would not necessarily be a bad thing. So remember, blood pressure is determined by cardiac output and total peripheral resistance. So even though we get that drop in TPR after training, and that is what would be lowering your blood pressure, if you were to get a massive increase in cardiac output, which can happen in some individuals, and that kind of offset that decrease in TPR, then theoretically blood pressure could be, maximal blood pressure anyway, could actually be higher after training. So this one varies depending on the person. But most textbooks are going to tell you that maximal blood pressure drops after aerobic training. As far as muscle blood flow, similar to AVO2 difference, at rest you wouldn't expect major changes because muscles don't need that much blood flow during rest, but maximal exercise, you're better able to redirect blood to active muscle. So that maximal blood flow during exercise would increase after aerobic training. The rate pressure product, which is determined by heart rate and systolic blood pressure. Now that we know what happens to heart rate and what happens to blood pressure, resting RPP will be lower because we have a lower resting heart rate, lower systolic blood pressure at rest. Submaximal exercise, same thing. And then maximal exercise, it may not change that much, but it's going to be totally dependent on how maximal heart rate changes, and we said probably not at all. And then whether systolic blood pressure comes down or goes up or stays the same after aerobic training. So maximal RPP really just depends on how those variables respond. But it's more clear-cut at the resting level and the submaximal level. You would expect RPP to be lower after training. As far as VO2 max, which is our number one indicator of aerobic fitness, as you would expect, it's going to go up. And there's a lot of variability in how much it will go up. So by VO2 max going up, that tells us that we're more aerobically fit after training. So most books will say on average the percent increase in VO2 max after aerobic training is anywhere from 5% to 30%, which is a pretty big window. So why such a big window? You got a few things going on. You have genetics, which play a huge role in VO2 max, and then you also have the person's initial level of fitness that's important. So somebody who starts out really, really unfit and their VO2 max is really low, they have a greater ability to improve, and they can increase a greater percentage. If you already have a relatively decent VO2 max, even though you may train the same amount as somebody who's lesser fit, your VO2 max may not go up as much just because you're starting at a higher point. So in addition to that, the amount of training is important. Age could affect it also. If you get into like the training program, intensity is important. If if you exercise at a higher intensity, that generally leads to greater improvements in VO2 max. But you could also discuss things like frequency, greater frequency of exercise, greater VO2 max, greater duration of it during an exercise bout, that could lead to greater VO2 maxes. So what determines VO2 max? Here's the Fick equation that we've seen before. So if we just rewrite the Fick equation for VO2 max, it looks like this. And from our discussion so far, we know what happens to each of those variables after aerobic training. Maximal heart rate, we said, doesn't change that much, or doesn't change consistently. Maximal stroke volume goes way up. Maximal AVO2 difference goes up. So out of these variables, maximal stroke volume, maximal AVO2 difference are responsible for increasing VO2 max after aerobic training. So what are the mechanisms? We briefly discussed this earlier, but just to talk more about it, preload, afterload, contractility. Those are the variables that determine stroke volume. So does preload increase? Yes, pretty drastically. So we talked about that improved filling of the heart after training. We talked about that increase in blood volume. We talked about the increase in chamber size. All of those things help increase preload, which is going to increase stroke volume. Afterload, to get an increase in stroke volume, we would have to have afterload go down, and we talked about how TPR, total peripheral resistance, goes down, and that's going to facilitate increases in stroke volume. And then contractility. We didn't really talk too much about this, but there is some evidence that you can increase the forcefulness by which the heart contracts after training. So contractility would increase also after aerobic training, adding to the increase in stroke volume. But out of the three, the changes in preload seem to play the biggest role. As far as AVO2 difference, and this is our oxygen extraction, so increases in mitochondrial density, that's important. Increases in capillarization, so more capillaries in the blood. And then also increases in myoglobin, which is the protein that transports oxygen within skeletal muscle. And from what you know about different types of muscle fibers, the improvements that you would see in these variables would be more so on the type 1 fibers, the aerobic fibers, the slow twitch. So this is kind of a flow chart discussing what we talked about. So after training, VO2 max goes up. That goes up due to increases in cardiac output and AVO2 difference. The cardiac output is solely due to an increase in stroke volume because we said maximal heart rate doesn't consistently change. That stroke volume is a result of increased preload, reduced afterload, and then we also added contractility in there. And then the AVO2 difference, capillaries, mitochondria, we also threw in myoglobin. So after training, if you detrain, VO2 max will decrease, as you might expect. And the mechanisms for that decrease in VO2 max are pretty much the opposite of what we talked about. So stroke volume goes up, AVO2 difference goes up. With training, those variables are going to come down during detraining, and thus lowering VO2 max. This is a nice figure showing the results of a study that was done years ago with detraining. And if we look at 0 time point, so we'll say at this 0 time point, the people were well trained. So they had just undergone a period of training, and then they undergo a period of almost 3 months of detraining, not exercising at all. So as you would expect, their fitness level seems to change during that detraining period. So let's look at VO2 max first of all. That's the squares. So VO2 max comes down pretty rapidly at first, and it looks like there's kind of a delay, and then it kind of continues to go down over the next 2 months or so. So there's an initial drop within the first 2 weeks, it looks like, and then there's a slower drop, sustained drop over time. So what's causing it? Well, let's look at the variables that determine VO2 max. Here is cardiac output, and cardiac output looks like it's basically mirroring that initial drop. So, and then it looks like cardiac output kind of plateaus a little bit, whereas VO2 max continues to go down. So what does this mean? Well, looking at this, it seems like that initial drop in cardiac output is the key reason that you get that initial drop in VO2 max. And let's even look closer. We know the two variables that determine cardiac output, heart rate, stroke volume. So maximal heart rate looks like it goes up initially for some reason I can't explain, and then it stays relatively constant. Stroke volume, on the other hand, drops drastically, quickly. And it looks like cardiac output and stroke volume pretty much mirror each other. So I think it's safe to say that stroke volume is determining cardiac output, kind of like we talked about, because maximal heart rate doesn't change that much after training. So key point, the initial drop in VO2 max within the first 2 weeks is primarily due to a drop in maximal stroke volume, which is reducing maximal cardiac output. The more sustained drop in VO2 max that you see over the next several months, or next 2 months at least, looks like it follows this line. This is your maximal AVO2 difference. So it looks like maximal AVO2 difference is not really changed that much at first. And then for some strange reason, it may actually increase a little bit, or it does here. And then you get that slow decline. So looking at the way VO2 max decreases and AVO2 difference max decreases during this latter part of the time period, looks like they're right in line with each other. So slow sustained decreases in VO2 max after the initial month or so, or 2 to 3 weeks or so, seem to be more due to decreases in maximal AVO2 difference. And I'm just going to say one more thing about this graph while we have it up here. You may be wondering why that is. Well, remember, one of the variables that determined stroke volume was blood volume. We said that's one of the first adaptations we get. Well, it's also going to be one of the first adaptations to leave. So we can get that increase in stroke volume quickly, but we can lose it quickly also. Whereas the AVO2 difference is primarily determined by capillaries and mitochondria. It takes longer to get those adaptations, and it's also going to take longer to get rid of those adaptations for them to leave. So the reason you see these kind of different timing rates of decline of these variables just depends on the mechanisms involved. It's easier and quicker to reduce blood volume than it is to actually lose mitochondria and capillaries. So another graph, and this one's not quite as interesting, but it does show you mitochondrial content. So with training, mitochondria increase as we said it would, and then if you start detraining, it's just going to reverse itself. And I guess the only other interesting point of this graph is that if you do not fully detrain, you can start to get it back. So if you undergo a brief detraining period but then start training again, it's easier and quicker to get those adaptations back.